The current state of primary care and the Affordable Care Act, along with considerations under the new administration, by Briana Williams, Morgan Vandall, and John Speights. Primary care is widely acknowledged to be essential for better health and well-being in the U.S. healthcare system and should be foundational to all healthcare systems worldwide. Access to high-quality primary care can help people live longer, feel better, and avoid disability. Primary care has experienced significant changes in the way it is organized, financed, and delivered in response to greater demand for high-quality services, rising costs, and increasing burden of disease across populations. Concepts such as patient-centered medical home emerged to describe a more advanced model of primary care. Primary care includes health prevention, disease promotion, health maintenance, counseling, patient education, disease and treatment of acute and chronic illnesses in a variety of healthcare settings. Primary care is performed and managed by a personal physician, often collaborating with other healthcare professionals and utilizing consultation or referrals as appropriate. Primary care provides patient advocacy in a healthcare system to accomplish cost-effective care by coordination of healthcare services. Primary care promotes effective communication with patients and encourages the role of the patient as a partner in healthcare. The Affordable Care Act, also known as the ACA or Obamacare, is a nickname for the Patient Protection and Affordable Care Act, a health reform law signed on March 23, 2010 by President Barack Obama. The Affordable Care Act was generally passed to address different aspects of the ongoing healthcare crisis in the U.S. In other words, it was meant to address the rising costs of healthcare that were leading to tens of millions of uninsured, bankruptcies, price discrimination based on gender and health status, and even denials of coverage for those with pre-existing conditions. The Affordable Care Act aims to provide more Americans with access to affordable health insurance, to improve the quality of healthcare and health insurance, to regulate the health insurance industry, and to reduce healthcare spending in the U.S. The law attempts to accomplish the above through a number of regulations, taxes, tax breaks, mandates, and subsidies. For example, the regulations that stop insurers from denying coverage to those with pre-existing conditions, subsidies on health insurance premiums and out-of-pocket costs, a mandate for large employers to provide full-time employees health insurance, and taxes on those who profit due to the expansion of healthcare like drug companies. In 2014, 6 in 10 people without health insurance could get a plan for $100 or less. In 2016, 7 out of 10 marketplace customers were able to get a plan for less than $75, and 8 out of 10 less than $100. The Affordable Care Act has increased primary care utilization. There has been an emphasis on care coordination, improved chronic disease management, greater access to primary care, and administrative simplification. The program overall has reduced monthly Medicare expenditures per beneficiary by $14 or 2%. Although the practices showed a significant reduction in emergency room visits and inpatient hospitalizations, nothing has been indicative of meaningful improvement in quality of care after the first year of the ACA.
Trump ran on a campaign that if he were elected, many changes would be made to the Affordable Care Act. Since his election, Trump's administration has stuck to this promise and has created many changes to the Affordable Care Act. The first steps that were taken against the act was canceling advertisement about marketplace coverage with the Affordable Care Act. This action likely caused a suppression of enrollment for the Affordable Care Act and caused more individuals that likely would have qualified for Medicare and Medicaid to not gain access to health insurance. The level of outreach meant to be able to be made was not successful, and Americans in impoverished areas or those with a limited health literacy were the ones to suffer the most from these mandates. The way the new administration handles cost-sharing reduction payments to insurers is also very different from the original image of what the Affordable Care Act was expected to be. The federal government makes payments to insurers to cover additional costs, according to Larry Levitt in his article, Is the Affordable Care Act Imploding? These cost-sharing reduction payments have been under scrutiny while Obama was still in office when the House of Representatives sued the administration for claiming the authority to make these payments. With Trump taking office, whether these payments would continue had been very much up in the air, many expecting them to cease altogether. This caused widespread insurer exits of the Affordable Care Act, as they were no longer promised the same profits as before. The administration under Trump did eventually decide to end the cost-sharing payments. Finally, when the Trump administration took over the executive branch of government, Republicans also took control of Congress. It was in this legislative branch that the individual mandate was repealed. The individual mandate was meant to fine individuals that were not insured. With the repeal of the mandate, Republicans made a major legislative dent and also allowed them to increase tax cuts included in legislation. This would increase the number of uninsured, as there would no longer be a penalty for those not wanting to purchase insurance, but it would also cause premiums to increase on private insurers due to adverse selection. While this was the largest change, there are many signs that the Trump administration are continuing to make changes to the Affordable Care Act to eventually undo it altogether, following through on the campaign's promise back in 2016.
Currently, the biggest problem in primary health care is the simple fact that there aren't enough physicians to cover all of the population, and the rate that the elderly population is growing is faster than the rate that new physicians are being made, causing the gap to continue to grow. In 2016, more physicians retired than graduated medical school. This results in some people unable to access medical care, and those that do are often rushed through the system to both maximize profits of the hospitals and to help see the most amount of people. There are other problems such as limited access to primary care physicians, but most of these problems stem from the fact that there aren't enough general practitioners to cover everyone everywhere adequately. The good news is that there are several possible solutions to help reduce these problems. The first and most obvious answer is to train more doctors to be general practitioners by either subsidizing their education or their pay, making the position more competitive with other medical specialties. Another viable option is to redistribute the workload among other jobs associated with the medical field. If things like preventative care and more straightforward cases are taken care of by various nurses and technicians, then the burden would be greatly reduced for primary care physicians. This would be harder to implement and regulate, especially with a complex insurance system. However, shifting more responsibility to other, less skilled positions can free up doctors to help and potentially cover more people. The Affordable Care Act had three primary goals when it was created: to decrease the number of uninsured people, to reduce the cost of medical care, and to improve the outcomes of provided services. The first goal had significant success, reducing the percent of uninsured people from 15.4% in 2008 down to 8.8% in 2017. And while an economic improvement may be partially responsible for the success, it is safe to say that the ACA significantly contributed to the nearly 25 million new people on insurance. On the downside, the part of the law that penalized people for not having insurance, the individual mandate, was specifically blocked, giving no incentive to have insurance regularly. And when you combine this with the parts of the law that make insurers accept all people with pre-existing conditions, and the part that makes them charge everyone the same amount, you get people who are uninsured and then purchase insurance when a problem arises, and then drop the insurance when the medical issue is taken care of. This is bad for insurance companies who need healthy people paying into the system regularly to not go bankrupt. On top of this, the marketplaces for the insurance policies that were required by the law were mostly ignored by the Republican states, and the Democratic states and federal ones that were created were confusing and poorly designed websites, resulting in an unsatisfactory experience. Another major problem with the bill is that it did nothing to control costs of the medical care the insurance companies are now required to pay. In addition, an argument could be made that it made outcomes worse on average by increasing the insured population by so much and doing nothing to increase the number of doctors or medical personnel in general. This is felt most in rural areas, but it can be seen in major cities all across America. Some possible solutions to these problems are policy contracts that specify a minimum time length that you have to keep the insurance for, or a fee is charged, similar to phone service providers' early cancellation fees. The government also should invest more money in the web designs of the marketplaces to make them more user-friendly and more reliable, as well as offering a free template to copy for states to copy. A separate bill should also be passed to either regulate medical prices or at least force medical providers to list all possible fees up front. And lastly, the government should subsidize all medical schools with extra subsidies for those people who do become rural doctors to help increase the overall number of doctors and increase the health outcomes overall. How can we continue to improve enrollment in health insurance plans when a significant amount of people believe that not having insurance should be a right and that the government does not have the power to mandate having insurance? And how can the government incentivize physicians to go into general practice when the specialties are more lucrative and at times easier than general practice, especially with the exorbitant prices of medical school?